Good morning and welcome to our UBC Learning Circle, centering community-led responses to toxic drugs crisis, learning from phase 1 of FNHA's Indigenizing harm reduction study. Today's conversation is presented in partnership with the Center for Excellence in Indigenous Health, and we'd like to thank the First Nations Health Authority for funding the UBC Learning Circle and allowing us to have these conversations. Before we formally begin, I'd like to acknowledge with respect and gratitude that I'm joining you from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Feel free to introduce yourselves in the chat box and the nation you're calling in from. And for those of you who don't know me, my name is Serene Squawkin. I am the Learning Circle Manager. I am Syilx Okanagan on my mother's side and Hickory Apache and Belgian settler on my father's side. I will be the moderator for today's discussion, and working behind the scenes will be our two assistants, which is Kira and Ella. They'll be interacting with everyone in the chat. And finally, before we get into today's discussion, I'll provide a gentle heads up that the topics covered may be sensitive or emotionally triggering, so feel free to talk to an elder, friend, counselor, or family member if you need additional support. There will also be prompts in the chat if you would like additional resources. Now I'll turn it over to our guests to introduce themselves.
So much, Serene. Aaliyah, I'm not sure if you wanted to pull up the slide deck for us to get started. All right. I hope everybody can see that okay. So Zinhan Zhu, good day, everyone. Really grateful to be joining you in this space this morning to share a bit about our work from learnings from the phase 1 of FNHA's Indigenizing harm reduction study. So this study is being led by the First Nations Health Authority in partnership with communities across the province, as well as with support and partnership from SFU and with funding from the Canadian Institutes of Health Research. So before we jump into our conversation today, I wanted to start with our protocols to share with you a bit about who we are, who it is that we belong to, the places we belong to and are accountable to, and how it is that we're showing up in this work, in this conversation today. So Sai Sozi Ashley Simpson. On my mom's side, our family is Wet'suwet'en from Hagwilgit Village. We are Gitumden Bear Clan. And on my father's side, we're English and Scottish, and I'm a very grateful uninvited guest here on unceded Coast Salish territories, the lands of the Snuneymuxw First Nation. And I have the privilege of working as a project director for Indigenous harm reduction research at the First Nations Health Authority and working alongside my colleagues, Aaliyah and Amity, and very privileged to get to support this work with First Nations communities across BC. So looking forward to our conversation today, and I'll pass over to you, Amity, to offer an introduction.
Thank you, Ashley. Hello, everyone. My name is Amity Mehta, and I'm a settler from Punjabi ancestry. I am calling in today from the unceded ancestral territories of the Samiamo First Nations people, where I have the privilege of working, playing, and living, and also raising my beautiful family. I work as a senior research coordinator on the Indigenizing harm reduction study, and we're really looking forward to our conversation and presentation today and highlighting more about our phase 1 and phase 2 of the study. And I'll pass it to Aaliyah.
Thank you, and hi everyone. My name is Aaliyah Gavorchan. I'm a settler of mixed European ancestry, Croatian on my dad's side and English on my mom's. And I'm very grateful to have been born and raised on the unceded and stolen lands of the Musqueam, Squamish, and Tsleil-Waututh nations, where I've lived for most of my life. I'm very grateful to work at the FNHA as a settler researcher. My position is research analyst, and I work on the Indigenizing harm reduction study with Amity and Ashley on the research and knowledge exchange team. I've been here for about 1.5 years, and this project is very close to my heart. And I'm just very excited to be sharing findings from the study. We're really looking forward to being here today and answering questions. So with that, I will get us going.
So just a bit more about the IHR project team. We have a diverse team of folks that are supporting this project. Our principal investigator is Dr. Courtney DeFriend, who is also the Executive Director of Research and Knowledge Exchange and Health Surveillance Team at FNHA. For our co-investigators, we have Dr. Brittany Barker, Dr. Pyle Batra, Dr. Jeff Reading, Dr. Krista Stokaya, Dr. Kelsey Louis, Katie Hughes, Alexa Norton, Caitlin Shane, Jody Millward, and Michelle DeCrude. And as we previously mentioned, our study team is Ashley Simpson, Aaliyah Goverchin, and me, Amity Mehta. We also have two artists who have been supporting this work, Jesse Ricolma and Ocean Highland, and they have been supporting the phase one work of the study by providing beautiful artwork that to enhance these findings. Thank you, Leah. So just a brief overview with regards to what this presentation is about. So firstly, we will be providing an overview of the Indigenizing Harm Reduction study, share learnings from phase one of the study, share the knowledge sharing and validation activities, and provide the overview of the current work in phase two. Just a bit more about the context of the IHR study. Due to colonial policy, systemic racism, and institutional neglect, First Nations people in BC continue to be overrepresented among toxic drug poisoning events and deaths. And due to the toxic drug crisis, First Nations people experience a decrease of life expectancy of 7.1 years between 2015 and 2021. As a result of an unprecedented increase in drug poisoning events and deaths, many health organizations have introduced and scaled up harm reduction services and programs to support people who use substances. Although mainstream harm reduction services have been successful in averting various overdose events and connecting individuals with essential services, they often are unable to address the broader systemic barriers that intersect with substance use for First Nations people and not holistically meet the needs of First Nations people who use substances and their communities. Also, there is limited research conducted with Indigenous communities impacted by the toxic drug crisis in British Columbia. So the purpose of the IHR study was to develop a nation-led, community-driven holistic model of harm reduction adaptable to the cultural and contextual needs of First Nations community in BC. The study aims include firstly, to reduce and prevent substance use harm, overdose and deaths among First Nations people who use drugs, promote individual and community health, wellness, and healing, increase knowledge and support of First Nation-led responses to the public health emergency. So the study will be completed in 3 phases. The phase 1, which is the knowledge synthesis phase, aims to weave together existing and new knowledge on culturally grounded wise practices in First Nations community-led harm reduction. The phase 2 aims to fund, support, and better understand BC First Nations-led harm reduction initiatives to determine what makes harm reduction services effective and meaningful. And phase 3 aims to use the knowledge from phase 1 and phase 2 to develop an adaptable BC First Nations harm reduction framework based on community-led models of care. So we will now debrief a bit more about our methodology in phase 1 and our ethical and methodological approaches to synthesizing knowledge. Given that there is limited literature about the First Nations harm reduction practices in BC, and our goal of creating a First Nations harm reduction framework necessitated the need to gather new knowledge about the First Nations approaches to harm reduction through qualitative methodologies. And we also have a recent publication in the International Journal of Indigenous Health, which kind of highlights about our 2-18 methodology and that we undertook in the first phase of the IHR study. Here is like a brief link or like a description of like the paper that is currently published. So the phase 1 of the study was guided by an overarching Indigenous research paradigm that shaped our study design and ethical considerations. Within an Indigenous paradigm, research is relational and researchers are knowledge producers. And researchers as knowledge producers hold responsibilities to engage these relationships ethically. Researchers are answerable to communities and environments involved in research process. So Tuatsin is a relational paradigm that encourages us to work together respectfully across different worldviews and use strengths of Indigenous and Western knowledges and ways of being for the benefit of all. Applying Tuatsin in knowledge synthesis within the IHR study enables us to garner a more holistic understanding of Indigenous approaches to harm reduction, grounded in experiences, priorities, and needs of Indigenous communities. Given the purpose of phase 1 of the IHR study, which was to generate a holistic understanding of the approaches of harm reduction for substance use for First Nations in BC, we first aim to situate our team's work within the global landscape of Indigenous harm reduction knowledge using a scoping review methodology. And due to limited literature on First Nations wise practices in harm reduction and to increase our understanding of the BC First Nations harm reduction approaches and community-driven solutions to toxic drug crisis, we conducted qualitative interviews. The aim of our scoping review was to gain understanding of the Indigenous approaches to harm reduction at a global landscape, that is from Australia, New Zealand, USA, and Canada. The review was guided by the methodological framework proposed by Artsy and O'Malley. And the research questions guiding our scoping review were, what are the wise practices in Indigenous-led harm reduction approaches for substance use that have been developed in Canada, United States, Australia, New Zealand, and what are the implementation challenges and successes of these interventions? Our search strategy included, firstly, conducting a review of published peer-reviewed literature from 2013 to 2023 using Medline. And next, a gray literature search was conducted to include literature on community-led or community-grounded harm reduction services or programs for Indigenous people. So a total of 23 published sources were included in the final review, and 14 gray literature resources were identified. To increase the understanding of the BC First Nations harm reduction approaches, barriers, and community-driven solution to the toxic drug crisis, we gathered knowledge through conversational interviews and structured questionnaires with First Nations individuals with lived or living experience accessing harm reduction services, as well as with individuals and as well as with individuals who identified as Indigenous or non-Indigenous service providers engaged in delivering these services to First Nations communities between 2023 and 2024 from each of the 5 health regions in BC. Study participants were recruited from 2 groups. First are the Indigenous harm reduction grantees, which are defined as those who received a grant in 2022 or 2023 from FNHA to begin or continue community-led harm reduction initiatives. And second are the harm reduction community champions. These are the folks who are defined as those who hold a knowledge or had experience with or about the impact of toxic drug crisis in community-led and community-based approaches to health and harm reduction. So as a part of our commitment to relational accountability, Indigenous peers with harm reduction expertise were invited to participate as co-interviewers with the study team in interviews with the harm reduction grantees. Peer interviewers completed the mandatory Canadian training for research involving humans prior to conducting the interviews and were compensated $30 per hour for all the activities related to the study. Mentorship and interview training sessions were offered by IHR's team members, which fostered relationship building and co-learning. Peer co-interviewers were recruited from IHRCC and through their relational networks. The interviews typically lasted for 1 hour, and we also did 2 virtual knowledge sharing circles with peers and study participants to validate and receive feedback on preliminary findings. And these circles created space for participants to share their experiences and best practices, which supported co-learning. And peers were also invited to write, review, and co-author on manuscripts for publication.
And now I'm going to shift over to share some of the findings from the first phase of our research. And today we're just going to be discussing the qualitative findings that came from interviews and surveys that were administered to folks who participated in this study. We're really looking here to just center community voices and participant voices. So we've included lots of quotes throughout, and we're hoping to take a pause for questions after we've given an overview of the findings. So to begin, we wanted to share a major finding that came out of our analysis, which was a definition of harm reduction for First Nations people in BC, which was informed directly by participants. And what this definition does is it expands upon mainstream approaches to substance use to include things like culture, traditional knowledge, ceremony, values, and Indigenous ways of being when caring for our relatives who use substances. This definition is represented here by the medicine basket, which represents the careful and respectful gathering of medicines to support our relatives who use substances, guiding them along their healing journeys. We've shown this in 4 key divisions. The first is relational practice, meaning that First Nations harm reduction is rooted in relationships, connection, and love, and acknowledges that a relational approach to care is foundational for building trust and creating a sense of safety and care for our relatives who use substances. We've included quotes from participants to describe this as well. The second is person-centered care, which means respecting an individual's needs and autonomy when determining their care plans and meeting individuals where they're at in their healing journey without judgment. The third is strengths-based approaches. Participants shared quite widely that First Nations approaches to harm reduction draw on ancestral strengths of culture, kinship, and community, and provide unconditional love and inclusive care for community members. A lot of participants articulated that culture is for everyone, wherever they are at in their healing journey. So for folks who are using substances, who may traditionally have been absent from these types of programming, culture is for everyone, and that came out very clear. It's also about helping people find healing through non-judgmental care. Another aspect of this theme was empowering peers or people with lived or living experience of substance use to design and deliver programs, given their expertise and the way that they're able to provide a sense of safety and belonging to individuals who are accessing harm reduction services. And lastly, holistic health was a major aspect of this definition. And it means providing care that wraps around individuals to support their holistic health, which includes physical, spiritual, mental, emotional, and collective wellness across a full continuum of care so that individuals are supported at all stages of their wellness. This kind of speaks to the last point, the concept of providing holistic care or holistic support across the continuum of care. This was another key finding. So this means providing care from prevention all the way to post-treatment and continued care, community reintegration. A lot of folks spoke about how this is critical to ensuring services that address holistic health across the life course. Many participants shared that programs are most meaningful and effective when they meet the diverse needs of community members, that they address social determinants of health or the non-physical individual level aspects of life that influence our health. So things like housing, food, access to services, for example, and that these are provided at all stages of service delivery. And the graphic that we have here is depicting the moon phases. And this, we thought, would symbolize the continuum of care really effectively in harm reduction, as just each phase of the moon cycle is equally valuable and important. So too is each stage of the continuum of care. And together they're able to represent a system that instills balance and well-being. Among the key findings were also ongoing gaps in the substance use care system and barriers that are continuing to exist that prevent meaningful harm reduction service provision. A lot of folks sadly shared that the toxic drug crisis in itself was a major source of ongoing grief for communities, which was leading to burnout, grief, and trauma. There were also many who shared that there was a significant need for more harm reduction services and supports, including supervised consumption sites, access to naloxone, OAT, and safer supply. One participant from the Vancouver Island region mentioned that I think one of the barriers is that people keep dying. It's a really big uphill battle, like when you're battling and trying to make a difference and you're constantly faced with people around you dying. And unfortunately, this was a major theme in our work, and we wanted to highlight this to get started in this section of the findings. Part and parcel to this was the concept of capacity and funding constraints. A lot of folks identified a need for more sustained and flexible, reliable funding for effective operations and cultural programming. A lot of folks mentioned that there was excessive overtime and understaffing for frontline staff, which was leading to retention challenges and burnout. Service inaccessibility was another challenge, and this included limited availability of substance use services in communities. This was especially highlighted for folks in rural, remote, and northern communities where access is a bit more unreliable, and services are often farther geographically from communities. And treatment barriers were shared by a number of participants, and some of the issues included really long wait times, restrictive admission criteria, very complex and laborious application processes to get in, a lack of culturally safe programs, and a predominance of abstinence-based programs, which makes it difficult for folks to stay in treatment. Other challenges that are systemic were related to racism, discrimination, and the impact of colonial systems of care. There is definitely a clear need to address ongoing harms of colonization and programming, addressing systemic racism in healthcare, policing, and criminal justice systems. One participant from the Vancouver coastal region mentioned that we redefined what harm reduction is to Indigenous people, because it's not just to do with reducing the harms of substances, but also reducing the harms done to Indigenous people by the continuation of colonization and systemic racism, which I think is the root cause of these challenges. Stigma was another challenge in communities and from service providers towards substance use, which a lot of folks mentioned was perpetuating shame and promoting service avoidance. As one participant said from the northern region, stigma is still the #1 barrier to keeping people safe, alive, and supported to heal. There's so much shame and blame around drug use, and it leads to so many stigmatized activities. We're now going to shift to sharing paths forward and wise practices that were identified by participants. And when we say wise practices, we mean practices that are being carried out at the community level and by First Nations led and serving organizations that are working really well to support people who use substances. Culture was kind of the overarching theme shared by most participants in the study. Cultural inclusion was one aspect of this, so ensuring that there are opportunities for people who use substances to have safe and appropriate access to culture and ceremony, regardless of where they are in their healing journey. And a lot of folks spoke to the positive benefits and connections that resulted when folks had access to culture and ceremony, especially for those who are facing social exclusion. One individual from the island mentioned that every Wednesday on the block around Pandora, we have elders and drummers that come right down to Pandora and sit with us for about 3 to 4 hours. And we bring fry bread and fish soup or chowders down. It's a space for our people, our relatives that are on the streets, to connect back to ancestral strength, to sit with elders, to eat some of our ancestral foods, and just gain strength in that way. What's really exciting is that a lot of people shared examples like this, really including folks who are living in urban and away from home settings into programs that they would otherwise miss out on, and really showing a lot of care and compassion for folks who are living rough and unhoused on the streets. The outcome of these programs were extremely positive. And so when people, it's very clear that when people have access to cultural activities and ceremony, storytelling, art, and language learning, the benefits are profound And another aspect of cultural programming was, of course, land-based healing. As we know, relationship with the land has since time immemorial been essential to the well-being of Indigenous peoples. And a lot of participants were sharing examples of how they'd integrated land-based practices, everything from medicine harvesting to fishing or camping or brushing into their programs, and how this had provided healing in ways that traditional or Western, I should say, Western treatment programs had not really been able to achieve. So from this work and from this theme, it's very clear that increasing access to culture and land-based healing leads to a greater sense of cultural identity and belonging. Connection and relationships were another major theme. A lot of participants shared that harm reduction as a concept is rooted in values like respect, love, and compassion, that it involves taking a lot of time to build trusting relationships with clients, that it involves treating everyone like family. One participant from the Central Interior Native Health Society shared that we have a monthly breakfast down in our cultural space and it's open to everybody in the community. We get about 85 people sometimes that attend, and we have a peer there doing education around harm reduction supplies, around Narcan training, so people can get a refresher and they can just get all their supplies that they require. A lot of individuals also spoke to the strengths of providing opportunities for peers to design, lead, and deliver programs, and how this provides a really great sense of safety and belonging and acceptance for folks who are accessing services. Many were advocating for more peer inclusion and funding for peer-led services and their programming. Nurturing intergenerational connections and knowledge sharing, and also providing opportunities for families to heal and develop stronger relationships was also highlighted as a critical aspect of their community programming, and something that mainstream harm reduction services often neglect to provide. And inter-organizational collaboration. A lot of service providers were talking at length about the strength in working with other Indigenous organizations and communities, and how this is a way to both foster connection between programs and also reducing administrative burden and capacity challenges, and also financial constraints that a lot of organizations are facing right now. Going back to the concept of holistic wraparound care, the importance of providing wraparound care was woven through almost all interviews. So addressing mental, emotional, physical, cultural, spiritual wellness, that was a key aspect of the work. There are many folks who were talking about weaving together clinical and cultural approaches to care and harm reduction, reflecting kind of a two-eyed seeing approach to programming. So using the strengths of both Western clinical care and traditional healing practices, and how this helps support clients in accessing services that feel relevant to them. And again, kind of strengthening the idea of continuum of care, this came through really strongly in these discussions. So needing a full spectrum of care options, and that goes all the way from prevention to reintegration into community. There's one really beautiful example shared by a participant in the Fraser Salish region about how services can be blended together, woven together to provide both clinical and cultural approaches to care. She explained that we have a team here that does home support detox. We have a nurse, a doctor that would go in and check on the client as they're detoxing. We'll get the family to empty out a room. We'll get a candle. We have water. We have cedar boughs, traditional medicines to help cleanse and detox. Then we have elders who would go in and talk to the one who is detoxing and just have the full support with the cedar brushings every morning, or when needed, drumming and singing for the one who's detoxing. So these are things that we just don't really see in Western service provision. Detox, from all that I have understood, is an incredibly isolating and traumatic experience. Allowing family to be present and allowing cultural activities to be there to help provide a sense of safety and care, I think is a really critical aspect that organizations, Indigenous and non-Indigenous, should be providing to clients, just because of the power of healing that it provides. Moving on to accessibility of care, this was identified as a major priority in a lot of different communities. Many participants spoke to how they were ensuring cultural safety, offering programs that involve ceremony and culture, like the previous participant mentioned, delivered by Indigenous frontline staff and providing training for non-Indigenous staff to ensure cultural safety and anti-racist spaces. As a result, when this type of when these things are included, that just really increases the uptake of services by creating a sense of safety. Other participants also shared that they're increasing supply availability and mitigating community stigma by providing programs like after-hour care cupboards for harm reduction supplies or vending machines. A lot of folks were also doing backpack and outreach programs in camper vans and trucks and on foot. And this was identified as a major challenge in rural and remote and northern communities, just that the availability is often not there in the way that it is in urban settings. There was a really clear need expressed by many folks to address accessibility challenges. Another aspect of this was increasing transportation for folks to access services when they're not available inside communities. And there were some very creative ways that folks were carrying this work out. One individual shared an example at their friendship center about the feedback that they get from culturally safe counseling. A lot of feedback that we get is that clients wouldn't access counseling anywhere else. They don't feel comfortable going into any organizations or through other services. So I think that's a huge piece of what we provide, is that sense of safety and comfort for people who walk in the doors. And I think this is a really beautiful quote illustrating the importance of cultural safety. Finally, building community capacity to carry out harm reduction was a key priority identified by a lot of participants. Many spoke to the importance of offering training programs to staff in harm reduction, overdose response, mental health crisis response, and first aid to help keep people safe and reduce stigma. Hiring peers was another aspect of this work, as we've already discussed. And building community support for harm reduction was really recognized as a way to reduce stigma and increase community cohesion. So many communities were initiating programs to build awareness and more connection and just knowledge about harm reduction. One nation shared that what they're doing is a beaded heart and carved paddle. And so those members who will wear a heart or a paddle, their choice, on their chest, pinned on, that is assigned to community members. And that says, I am in a recovery journey and you can come talk to me anytime, so that we build some sort of community here in the village. So wearing something like a beaded heart or a carved paddle, that means and signifies to people who are using substances that that person is safe and that person understands and that person can be a source of support when they don't feel like they have others to turn to. That was a lot of talking. I'm moving on to just sharing our knowledge validation activities. So these findings that we've shared just now were validated in a few different settings. First of all, in fall of 2024, through a number of knowledge sharing circles. So we invited study participants and peers who had helped with the analysis of our findings to join 2 virtual circles where we shared our initial findings and sought some critical feedback, which was really helpful in making sure that we were on the right track with what we were sharing. We also held a number of co-investigator and research advisory committee meetings between 2024 and 2025 to share the draft of our phase 1 report, which is now publicly available online on the FNHA website. The summary of findings report, as I should specify. The phase 1 full report is incoming. It is under development. We also had our infographics reviewed by our study team and our research advisory committee, and we sought feedback on avenues where we could share the phase 1 findings, attending sharing circles and events like the one that we're at today have been some of the ways that we've been disseminating findings. And then also through 2024 and 2025, we shared draft summary of finding documents and some of our infographics at regional caucuses to validate findings with health directors and community leadership in each of the 5 health regions in BC. So some of the work that we've done so far, we've completed 2 community-facing infographics with findings from phase 1 that should be put on the website, I hope, by the end of the year. We have a manuscript published discussing our methodology that we used, as Amity had mentioned earlier, describing our two-eyed seeing approach to generating knowledge, and a summary of findings report. Our full report is completed. It's not publicly available yet, but our summary of findings is, and this is what it looks like on the right here. It is on the FNHA website. It should be in one of the recent news releases as well. And it would have come out on an email blast, but we're happy to share the link out to everyone afterwards. We're also sharing, we're also working on another manuscript sharing the qualitative findings that we discussed today. That will be aimed to be out in the public by the new year. We're trying to submit that by late 2025. And we're also working with harm reduction client survey data right now to understand community access to harm reduction supplies and services among First Nations respondents. So we're hoping that maybe next year we can get an analysis out in the public about some of those concepts. And just to share again, like all of our research activities and our findings have adhered to First Nations OCAP, ownership, control, access, and possession principles. That's been a really important part of our ethical work, and that will be shared in more detail later on by Ashley. So I just wanted to take a pause just because we've been talking for a while and see if there's any questions that have come up or any reflections. We'd be really interested to hear anybody who would like to share about their experiences providing services, accessing services, doing research in this area, anything that folks are wanting to share. We would love to open the floor right now for a couple minutes.
I think the most asked question is if you guys are going to be sharing the slides afterwards. That's the main question I've been seeing. And then the next question is, someone was just mentioning how it's a challenge in outreach for homeless people, and how loved ones, like how can we create an opportunity to support our homeless and folks who are in active addiction, while also not, yeah, sorry, I'm trying to, the question's kind of worded weird. I'm just gonna pop it in the chat just to, so you can see as well.
Thank you. I will say we are happy to share slides afterwards for sure. And we can share the link to our summary of findings report, which goes into greater depth about what we've been speaking to. It's a bit more digestible. Ashley or Amity, do you want to tackle the next question, or should I take it?
Yeah, I'm just taking a look in the chat here. So challenges in outreach for homeless loved ones. How important is physical outreach to homes, streets? With a few loved ones in active addictions, our community stopped going to them. And yeah, that's tough. And I think we heard a lot from folks around resources constraints, around staffing shortages and things too for outreach programs. And that's certainly a struggle for communities and organizations across the province. And I think what we heard loud and clear was that connection and that sense of belonging, and whether that's through access to ceremony or a relationship with family or connection to peers and things. So if there's other ways of connecting to folks who are not living in community or living close by or maybe unhoused, then yeah, trying to maintain that connection as close as you possibly can, I guess. And without outreach supports, that's really tough, because I think that's how a lot of folks are reaching the supports and the services that they need, and getting kind of linked in with what's available, and maintaining that sense of connection and community is through those outreach spaces. And we've also seen a lot of really beautiful examples of kind of folks on the street leading the charge in that regard, and kind of creating those spaces for themselves, and bringing people together and creating community with the folks, with peers and folks that they're living and kind of walking that journey alongside. So I don't know that I have an answer to that from what's come forward to us, because we're also hearing that that's been a huge barrier and challenge for folks. Aaliyah or Media, I don't know if you had anything else that you wanted to add to that.
I guess I would just piggyback onto that. The comment of supporting folks who are unhoused. I think that's just an incredibly important thing that fortunately communities are providing and Indigenous organizations are providing. And I say that just given the hostility that we're experiencing in BC, Vancouver, and Canada more broadly towards unhoused people and people who use substances. So providing a strong opposition to the rhetoric that is pervading our media and ideology about and narratives about people who use drugs is really important. And I'm really, really like optimistic and hopeful to see that there are communities providing this type of care in the absence of really meaningful support being provided by governments right now. So that's what I would say. Ashley, I think you kind of covered it, but I think it's a big challenge and one that is very difficult to address right now.
We have a couple more here. How can you tell the difference between whether these methodologies reduce harm versus creating more harm to the individual and community? How are you measuring this data?
That's a great question. I think our intention of using this methodology in a research way. I know research has been very unsafe for a lot of Indigenous communities, for a lot of non-Indigenous communities too, folks who are unhoused and using substances. That research has not been a safe space to engage and to have dialogues and to have your voice and your experience heard. And so really walking alongside peers, drawing on the expertise and the knowledge of the peers that we work with to be checking us, keeping us aligned, making sure that we're, being safe and respectful when we're engaging in these conversations. And I think the validation, for lack of a better word, but really it's a checking in process. And so ensuring that the people that we're in relationship with through this knowledge gathering process, through our research, are letting us know and kind of keeping us aligned with the values that we're, holding ourselves to in this work, and making sure that we have lots of opportunities for dialogue and conversation, for folks to let us know if no, that's absolutely not what we shared. That wasn't the intention of, or our experience. And so really making sure that we have lots of pauses in the process to kind of do a temperature check and check in with folks to hear if this is aligning with, what they told us. And so a huge piece of Indigenous research, methodologies and kind of paradigms in this work and ways of understanding how we go about research work is that accountability. And so we're really take our responsibility seriously as, witnesses to a lot of these stories and experiences that have been shared with us, and making sure that we're kind of, a conduit to be able to share these stories and the good work that's happening across the province. And so we don't take that responsibility lightly. And that participants or storytellers, the folks that we're engaging with, our partners, our peers that we're working alongside, our kind of leadership and guiding research advisory committee members and things are kind of these safety checks to make sure that we're carrying out the work in the best way that we possibly can, and kind of upholding those accountabilities that we have as witnesses to these stories. I don't know, Amelia or Aaliyah, if you had anything that you wanted to speak to in that regard.
And just to add to what Ashley mentioned in terms of even when we were doing knowledge gathering with the participants, we had peers who were also involved with the knowledge gathering, and they would often take the lead at asking the questions. And the academic or the FNHA-based study team member would just be in a supportive role. So we were actually having this work to be more of peer-led, and having also, like as Ashley mentioned, like having this work validated by peers and community members at like many different stages through like knowledge sharing circles or doing member checking after the interviews that we did. So yeah, there was like a lot of opportunity to make sure that we were that the findings that we have are reflective of the community voices and are are not and are reflective of like what people are actually seeing and experiencing.
And I would just add, we're going to be discussing the next phase of our work, which is shifting to a more, it's shifting to community-based research. So we'll be sharing that after our slide. And I guess our hope with that phase of the work is to help build community capacity to conduct research and generate knowledge that can help advocate for policies and funding. I think that's the ultimate aim of our work, is to influence and use this information to be able to influence better funding and policies that are reflective of what First Nations communities are saying and advocating for and needing. But yeah, research it's not a perfect practice, and it's one way to generate advocacy. It's not the way, but I think what we've tried to really do in phase one is center participant voice and work to highlight strengths rather than deficit narratives. The majority of our summary report and our full report will be addressing really positive work that's being done as a way to help inspire other communities who might be looking to develop similar programming and for advocacy. But it's a good question, and it's important that we address it. And I hope that we can address it a bit more in the next phase of the work, but hopefully that does a bit to answer the question.
Yeah, our next question is just wondering about the team that provides home-based withdrawal management and funding for this, and compensation for those that provide the cultural work in other communities.
Yeah, that's a great question. So we have kind of various ways of sharing this knowledge. And so some community members have given their consent or their permission for their community or their name to be shared alongside, their stories, their teachings, the experiences, and wise practice examples that they've shared with us, whereas others have not. So we don't have permission, I think, to share detailed, I guess, a detailed response about how it was or how it is that that program operates on the ground in the community. But that's certainly something. So the next bit of our conversation is about phase two of the Indigenizing Harm Reduction study and this process of working alongside community-based pilot sites to really take a closer look at the aspects of community-led harm reduction programs, what's working well, what's not working so well, what the needs are, kind of understanding the impact and the meaningfulness of First Nations approaches to harm reduction care. And so in the first phase of the work, it was kind of an opportunity to really hold up and highlight these examples. And now this next bit of our work is really to kind of go deeper and understand what is it about First Nations approaches that are what about them are different from mainstream approaches, and what's working really well in supporting and holding up our community members who use substances. So I apologize, that's probably not the response that somebody was hoping for, but I'm hoping that those types of questions and really understanding what this looks like on the ground and in community and practice will be what we learn as phase two of the work unfolds.
I think we have a few more, but I think they might be answered in the next few slides. So why don't we get to the next few slides and we can read the rest at the end.
All right. So we wanted to have an opportunity to share with you a bit about where we're at in the project and how we are weaving in what we've learned through phase one into this next stage of the work. And so Our kind of formal methodological approach, I guess, is community-based participatory research, where we are funding and supporting community-based harm reduction initiatives and research projects across the province. And so, with direction from each of the 5 health regions across BC from regional leadership, phase 2 of this study really involves collaborating alongside BC's First Nations communities to enhance both new and existing community-led harm reduction initiatives to better understand the effectiveness or the meaningfulness or the impact of community-led interventions through community-based, community-led research and community-defined approaches to evaluation. And we're also looking to determine wise practices and indicators of successful or meaningful First Nations approaches. So we really want to understand, like I just mentioned, what's working really well, what is it about First Nations-led approaches to addressing the toxic drug crisis, to delivery of harm reduction care that is most meaningful for First Nations community members. And with that, the learnings will inform the development of a provincial First Nations harm reduction framework. So in 2024, communities across the 5 health regions applied for funding to enhance and better understand community-based harm reduction programming. Successful communities are now receiving funding and support from the FNHA study team, which is us, to co-design research projects to really understand what are the community needs and priorities and kind of research focus areas of interest. And to strengthen research capacity and in turn to carry out all research activities. And so these research projects will be ongoing now for the next year. And at the end of the projects, we will co-research or understand what made these projects impactful and meaningful for their community members. And then the knowledge gathered from these research projects across the province will help to inform community-led wise practices in harm reduction at a provincial level. And so regional leadership really determined what the funding distribution or how funds would be used within their regions to support the communities within their regions. They determined eligibility criteria, so what it was that was a priority in each region, because we know and acknowledge the importance of the difference and what the needs are, say on Vancouver Island are very different from what the needs and priorities may be in the northern region for communities. And so this selection process was really driven at a regional level with the hopes of ensuring that it was relevant and responsive to regional priorities. And so to really ensure that we were weaving in, what we heard from phase 1 and really centering those voices of folks that we spoke to through the first phase of this research, we carried that through in the consideration around who received this funding. And so proposed initiatives that addressed one or more of the 3 key priority areas were successfully selected and will be a part of this next phase of the work. And so the learnings from phase 1 really showed us, that culture was central to First Nations approaches to harm reduction in BC. And so initiatives that incorporate cultural elements such as language, land-based activities, ceremony in their harm reduction programming and services, really with that intention of fostering connection, identity, and well-being. Were selected, as well as the continuum of care. And so initiatives that foster service continuity and support across the entire continuum of care. So from prevention to harm reduction, maybe treatment or other programming, what it looks like when folks return to community after they've attended a program or service, that kind of reintegration and reconnection piece, and aftercare, as well as, these lifelong supports and services, acknowledging that healing is a lifelong journey. And so that can look like resources, staff, or other supports across the continuum. And so many communities are addressing several points across that continuum of care. And then finally, accessibility, which was a huge piece in the conversations that we had throughout phase one. And so initiatives that increase accessibility and availability of harm reduction programs and services for First Nations community members. And that could be through things like reduced physical or geographic barriers to accessing service, increasing availability of harm reduction supplies, reducing stigma, which we heard is a huge piece for many, many communities and organizations, as well as increasing access to culturally safe services, increasing access to Indigenous care providers, the inclusion of peers in programs and services, as well as, elders, knowledge keepers, increasing, the availability of kind of whole family approaches and things. And so accessibility captures a huge holistic kind of approach to these harm reduction services. And so you'll see, I think, in the next couple of slides that many of the communities we're working alongside are addressing many, if not all, of those pieces. And so I think a really important piece, we've chatted a little bit about this, but kind of the ethical considerations in carrying out health research, community-based research with First Nations in BC. So there's many different kind of ethical considerations that have been woven throughout our work. First and foremost, upholding community protocols. And so centering community ethical and cultural protocols in this research, acknowledging that many nations and organizations, both provincially and then, national level, have very rigorous and established protocols and ethical ways of conducting research and how it is that we engage with their communities when doing this type of work. And so relational accountability is a huge piece of that, and how it is that we hold ourselves accountable and responsible in carrying out research with communities. And so a piece of that is working on developing relationship and protocol documents with communities that really outlines and makes clear how it is that we work together over this next year and beyond in carrying out this work. And we also have a research advisory committee that guides us and provides support and leadership in holding us accountable throughout this process. I think, as Aaliyah mentioned, the FNIGC, the First Nations Information Governance Center, has the principles of OCAP, so ownership, control, access, and possession, when we're talking about First Nation specific data. And so communities are determining how this is applied within each of their particular research projects. And so communities tell us what information will be collected as part of this research, how and with whom it will be shared, and who has access to it, what they would like to do with it at the end of the project, all aspects related to the gathering of First Nations knowledge is driven by the communities that we're working alongside, which pieces are included in the larger IHR project, for example. And we also have additional guidance from our research advisory committee. So the First Nations Health Authority also has the 7 directives that grounds all of our work. And I think most importantly within this particular project, ensuring that the research is community-driven and nation-based, that we're increasing First Nations decision-making and control, and that we're working towards improving harm reduction and substance use services in community. And then finally, this piece around harmonized ethics. So the province of BC has an harmonized ethics review process. And so we are accountable to that as well. And so formal, institutional ethics approval is currently underway between the First Nations Health Authority, SFU, and UBC, who are our partners in this work. So we want to provide a bit of a visual map to share, kind of the scope across the province of BC. And so, as I mentioned, each of the regions determined how the funding and the resources and kind of this opportunity was dispersed across their region and across the communities that they serve. So in the northern region, we're working alongside 6 nations. In the Vancouver Island region, we're working alongside three, so to represent the three cultural families on the island. In the Fraser Salish region, working alongside two, and in the Vancouver coastal region, working alongside two as well. And we're currently working with the interior regional leadership to determine what this project and opportunity is going to look like in the interior and how we can support the communities in engaging in this work. So to be determined. So wanted to also provide a bit of a scope on, the holistic spectrum of projects that have been put forward by communities and the different ways that communities are approaching harm reduction work, and also addressing the toxic drug response within their communities. And so we have a huge range of ways that that's happening, and kind of research focus that we're supporting communities in carrying out and addressing. So one community is looking at integration of harm reduction principles and practices into the development of their holistic health emergency management protocols, and really taking a large scale kind of holistic scope of harm reduction as part of health emergency management, and how it is that they take care of their community members who use substances during times of health emergency or crisis. Another community is looking at culturally based outreach programming that fosters intergenerational connection and knowledge sharing. So bringing together whole families from youth to elders in these spaces to share, engage in, land-based or, community relevant activities, and really nurturing those connections across generations to really establish well-being and sense of connection. One community is looking at establishing a holistic integrated care model within mobile overdose prevention sites. So offering mobile outreach where clinicians, elders, peers, cultural pieces are all woven together in this really accessible outreach support type way, and understanding what the impacts are for their community members when that type of wraparound care is brought to them. Another community is looking at engaging youth in culturally grounded music making programming. So using culture and language and song and music as a way to enhance youth self-esteem and sense of identity and connection and belonging. And then we have quite a few communities that are taking a land and language-based approach to programming to really strengthen a sense of connection, belonging, and cultural identity. And so the next steps in our work are really nurturing and strengthening those research relationships through the co-development of our community research protocols, so that it's very clear, what our responsibilities are on the FNHA side of things, to be upholding community asks and requests for support in the pieces that they may need us to walk alongside them on, and understanding which pieces of the work communities want to lead, and which aspects of the knowledge are meant for community and community only. Research planning. So we're currently in the middle of research planning with most of the sites that we're working alongside, or most of the communities. And so really co-developing those research questions and study designs, and walking through how it is that communities want to undergo and undertake this work with their community members. And then with the direction from the communities, we'll be providing support and resources and additional capacity as needed for all research activities for the duration of our time in working together. So if anybody wants to learn more about the project or get in touch with us and chat a bit more, I think I saw a few things in the chat where there was, other projects and things that are happening elsewhere across Turtle Island. Please reach out to us. We would love to connect. We can share the slides. We can share the link to our recently released summary of findings report. And as Aaliyah mentioned, there's some infographics and things that we can get up on to our website so that there's links for those as well. But we would love to connect and hear about the work that you're doing and how some of this might overlap and yeah, just interconnect with the good work that's I know is happening elsewhere as well. So with that, I really raise my hands to each of you for allowing us to share this space with you this morning, maybe afternoon for some of you, but Tabby Masai, thank you so much, and look forward to answering any questions or hearing any feedback that folks might have.
Thank you. We have quite a few questions here. The first one is, did researchers hear feedback from peers where community members, especially elders who held outdated beliefs and any struggle to connect to culture and community with those communities, like members, leaders, elders, were still resistant to harm reduction?
I think if I'm understanding the question correctly, it's around elders maybe not being open to the concept of harm reduction or the inclusion of folks who are using substances in ceremony and culture. Is that correct?
I think so, yes. Or just
Yeah.
not being open to this new approach with harm reduction.
Mm-hmm. Absolutely. We heard, and not just elders, but knowledge keepers, folks who are, knowledge holders in the community around ceremony or cultural teachings. This has been a huge piece of the conversation that we've had. And I think really exciting every time we hear from communities about how they're finding ways to kind of bridge this and maybe reduce some of the stigma or maybe open up space for that conversation to start in communities. There's been a lot of really beautiful examples of like elders teas coming, elders councils, folks coming together where maybe there's one elder in the community that's championing harm reduction and is really advocating for the inclusion of folks in spaces. And so having these opportunities for elders to come together and have dialogues and be able to talk through what that looks like, acknowledging that it's going to look very different in different families, different communities, different regions, like at every level, that there's various levels of kind of safety and appropriateness and openness to holding that space. But there's some really beautiful examples of where it's working really well and where communities are coming together and there's an increase in, awareness of why it's important and how, central and important that connection to culture and ceremony is, and that sense of belonging and identity and purpose for folks who use substances. And so when it's kind of approached from that lens, people have shared with us that there's been a huge shift within their communities to finding safe ways. And maybe it's not maybe it doesn't look the same, and there might be some adaptations that are happening in ways that they can create safety while still adhering to cultural and community protocols around ceremonies, but creating new ways for folks who are using substances to still be a part of it and be engaging and and being able to participate in ways that are meaningful and bringing them together with their communities. Aaliyah or Amelia, I don't know if there's anything else that you wanted to add to that. We've had a lot of conversations about this piece, so I'm glad that it came up as a question.
Yeah, just add to like I really Ashley just like answered that question very well. Just we have had like even with phase two, like a lot of like communities share with us the resistance with regards to the term harm reduction and how there is stigma associated with the term harm reduction and how the community-based like leaders and like the people who are involved with harm reduction work and within communities are taking a more holistic and more like innovative approach towards like helping communities um, and looking at it towards like a holistic wellness approach rather than like really mentioning that it is harm reduction while doing harm reduction work, but looking at it through like a holistic uh, landscape and supporting people with their overall health and overall healing journeys.
Just to add on to that, that kind of like leads into another question. Sorry, Aaliyah, if you have something to add. I just thought this question really related to MIDI. When indigenizing this work, was there any consideration given to creating a term to replace harm reduction, like the words harm reduction? Sometimes those words is enough to turn people away. Like even just the word harm is kind of like that might throw someone off, you know. Was there any roundtable talk or anything about any other suggestions on the word choice?
Yeah, great question. The language piece has also been at the forefront of the conversations that we're having with communities, both when sharing about the research and the work that we're doing and how it is that the language is framing what it is that communities want to do. So we've had lots of conversations about harm reduction and specifically indigenizing harm reduction. So the title of our of the formal title of the study has been identified as being a bit problematic and that we need to find a new way of discussing and talking about what it is that's being done on the ground and that might not actually capture and accurately represent what the work is and what that relationship is. And so one of our questions actually in phase one was, you know, what does indigenizing or indigenous harm reduction mean to you? And so there was a lot of dialogue around that it's, you know, it's care, it's compassion, it's love, it's respect, it's meeting people where they're at. And so that's where we kind of got that definition with, you know, person-centered, strengths-based, holistic wraparound care from was because we weren't told, you know, this is what we want to call it, but this is what it is that we're doing. And so I would love to have more dialogue and more opportunities to talk through what that could look like in moving forward. And I think a lot of communities are also telling us now, as we're in this like community-led project-based phase of the work, that when we're talking to community members, not every community wants to talk about, you know, what does harm reduction mean to you? Or how does this support you in your substance use journey? And really approaching it from this holistic, strengths-based healthy lifestyle or wellness, well-being type approach, as opposed to that kind of like starting off from a bit of a deficit based place and really looking at it as like what keeps you well, and then like what role does culture have in that? What is the impact of being able to participate in ceremony and being able to be connected to your family and you know, your traditional territory, etc. And rather than starting and kind of framing the conversation from the harms based place. I think that that often happens. So it's been a really powerful conversation, I think, to talk about language and how it is that we actually describe and engage in these dialogues about the work that we're doing.
Thank you. Our next question is, are you looking into aftercare support in addition to harm reduction, or are you seeing it within your report as a part of it?
I would say that I can't remember if in our interview guide we specifically asked about aftercare support, but I guess I would say when we were going through transcripts, a major theme was a major gap was the lack of aftercare supports that are provided in traditional hubs, substance use programs, mainstream substance use programs. and that they are basically, when people go to treatment, they're just being let go without any type of supports, and that communities are the ones that are trying to do that in the absence of stable, consistent funding and resources to do that work. And so I guess what came out really clear is that like all stages of the continuum of care and substance use care cannot really be like they're all equally important. Like prevention is one aspect of it. Clinical care is one aspect of it. Providing culturally grounded services throughout and supports is an aspect. Aftercare is critical though, following treatment. Like we know that, and there is a lot of data that shows that it's like population level data that shows that this is like one of the major areas where people are being really let down in the Western colonial care system is like that lack of aftercare. I'm kind of going down a rabbit hole and going in a circle, I think, but I think I view it as an aspect of harm reduction care. Like if we're looking at the harms that we've described today as an outcome of colonization, then providing services that provide the opposite of what the colonial system has provided, grounded in a First Nations perspective on health and wellness and ways of supporting and existing with one another, like continuous care and connection is like a major aspect of harm reduction. And I think aftercare falls under that. So yeah, I guess we've defined it like we view harm reduction holistically on this project as a way to reduce the harms of colonization, not just the harms of substance use. So, and that's the way that participants have tended to describe it. Yeah, if anyone wants to piggyback on that answer, because I'm not sure if that was super clear.
We have a question that kind of like adds to that. We're just wondering if the project is starting to streamline the harm reduction, safe injection sites built into like a detox programs rather than create it as a public service to meet those who need this care more adequately. So put that in the chat.
Sorry, I hope my understanding of the question is accurate, and that this is the intention of the question. But certainly, I don't know about streamlining. I can't speak to that piece. That isn't language that communities or participants have used with us up to this point. But I think that approach of this holistic wraparound care model that seems to work really well. I know, not just within First Nations communities, but we see the success of that model, across communities and populations. And so we hear most frequently, I think, from communities that there's a need to bring people together so that, we're reducing geographic barriers, we're reducing, transit, having to go in between locations to access their services, that there's childcare, that there's transportation, that there's food available when they're attending programs, that peers are central in that there's harm reduction conversations, like all of these pieces kind of coming together and providing care in that really holistic wraparound way. And, we call it social determinants of health, but really it's like taking care of the whole person, the whole being, the whole family, and really making sure that all of those pieces are attended to. I think we had a quote from an urban Indigenous organization where they said, our families that we're serving are so busy just tackling these different systems and trying to have all of their needs met, feeding their children, getting childcare, getting to appointments, all of those pieces need to be addressed and taken care of before conversations about harm reduction and substance use and healing can really happen. And so I think that's such an important reminder about the power of coming together. And I think that's on the systems, that's on us to be collaborating and talking to each other and knowing, what's available and how we work together to make this, kind of network and circle of support around individuals who are seeking care. So I don't know if that's the question, or if that kind of addresses the specific piece around kind of streamlining some of these services. But I think that holistic, collaborative approach
I saw
is
in the chat,
yeah.
it looked like some people were highlighting that seems like a more grounded approach than just like a colonial perspective of like, let's streamline this and let's make this like a plan, because sometimes even that in itself doesn't has its cracks and whatnot. Whereas when you're looking at other areas to support, like food or community or ceremony and whatnot, then you're creating that sense of self and identity back that a lot of um, people who may be using substances may lack, and that's why they seek out substances. So I think that was beautifully said. This is the next question. How do you recommend to continue to fund these programs after a year trial? They found that in our health region, we often trial something for a year and then there is no additional funds to continue the program. What sort of plan is there, or funding in store for the longevity of this sort of work?
That's such an important piece and something that we've been really upfront and transparent about in this work when we're having these conversations with communities, is that research is not the best avenue, or when we talk about continuity and we're talking about this continuum of care and healing being a lifelong journey, and we're hearing about the very present and persistent barriers around funding and staff retention and just community capacity to carry out this work. And so that's a huge limit and kind of barrier that we're facing, just given the nature of the type of work that we're doing, that research funding is short term, and that it's not addressing these long-term pieces, and that we're engaging in these conversations to ask communities about, what are the challenges? And it's like, well, this is the challenge in and of itself. So a few communities that we're working alongside in phase 2 are actually using this opportunity as like a bit of a feasibility approach. And so making a case and using this research type funding opportunity to really make a case for why, their community program or their initiative is effective, why it's meaningful, why it's deserving of long-term sustainable funding. And so that's, their desired research output is being able to really advocate and leverage this opportunity for further funding. So that's one approach. Another piece that we're really weaving into this work is around indicators. And so developing these provincial level indicators to understand what it is that is meaningful. What is it that communities want to measure? What is meaningful? What is impactful? What does it mean for peers to be a part of programming, for culture and ceremony to be at the heart of programming? And so currently, with the indicators and kind of measurement tools that exist, both within FNHA and with partners, and federal and provincial funders for these programs, they might not be asking the right questions. And so part of our work in this developing this provincial framework is really looking at developing a set of indicators that actually tell the story that communities want told, and to be looking at the pieces that communities are telling us are important to be looking at, so that when we're talking with provincial partners and within FNHA ourselves and talking about funding and really advocating for community-led, holistic, culturally based, land-based approaches to mental health care, harm reduction care, substance use care, that we're really centering those values and those important pieces that are currently being missed in what's currently being measured. And so with the hope and the intention that that would secure, funding that is actually reflective of what communities are needing and prioritizing and asking for. I don't know, Aaliyah or Amity, if there was anything else that you wanted to add to that.
I would just echo that it's probably one of the most difficult parts about doing this project is the fact that we can't promise sustained funding. And I guess this becomes even more concerning when we see the federal budget release that just came out this week, which I recommend folks who haven't reviewed it to have a look at and see the cuts that Mark Carney's government is taking to Indigenous and First Nations specific health programming. This directly affects our ability to do our work and for communities to receive funding for programming, which is sad and unfair. But we hear you, and it's something that we really continually try to advocate for with our team and to our funders. But it is alarming. And yeah, as you've just said in the chat, Jamie, it's alarming and sad, and it's frustrating because we need the opposite of that happening right now. But thank you for bringing that up. And I'm sorry that as a team, we can't provide that assurance. It's difficult.
Thank you. We have another question here, just wondering, with the report, did you bring in peer Indigenous researchers with lived experience in substance use for either the current or future work? Another person said on another question, they found that a lot of the programs that were put into place in their community wasn't really being attended or used. And they were just wondering if the issue was maybe not having any peer-led support or someone with lived experience to actually help create these programs. And yeah.
I feel like I keep jumping in first, so I want to make space for Amity or Leah to answer if you had any thoughts on that first.
I could go first. Or Aaliyah, you could go first. That's fine.
No, I was just going to say, please go for it, Ashley. Take a crack at it, but Amity, please go ahead.
That was one of the wise practices that actually Aaliyah presented on today, was to have like peer voices in like designing and both in designing and delivery of the program. So yes, that may be one of the considerations to be reflected on, is like to have as much peer voices, because these are the people who have who are supporting the communities and have the lived experience. So yeah, maybe like Aaliyah could or Ashley could expand more on that as they presented on the wise practices.
Yeah, thanks, Amity. So in terms of kind of future work and ongoing collaboration with peers, the hope is any knowledge products. So writing manuscripts, for example, we worked alongside an incredible group of peers who were also our co-interviewers in phase one of the work to co-write and co-author our first manuscript that was published, and the hope would be to do the same for future manuscripts and things. Because of the nature of phase two, with the communities kind of telling us what they want, there may be interest from the communities to have a community-based peer from that community be involved as a co-interviewer or be a co-researcher, be the on-the-ground kind of coordination in that work. And so we'll kind of take a back seat and let communities tell us how they want, peers that they're involved with and have relationships with be involved. And certainly through our research advisory committee, having peer presence and through kind of our own interviewing or knowledge gathering that we'll do as part of phase 2 of the work. The aim would always be to have peer voices and peer expertise be working alongside us in that. And so there's kind of, I think, many different pathways of work that are happening as this next bit unfolds, and that part of it will be community led, and it may be peer-based researchers in those communities, which would be pretty incredible. And then we also have a network of peers that we have relationships through as part of a larger study that are very generous in their offers of support and willingness to work alongside us. So that is certainly our intention.
Thank you. That answered that question. And maybe just this last question, just to end in a good way, is just we're just curious if the community saw any use in virtual counseling with this program.
Great question. So we don't have any kind of virtual components as part of phase 2. So the communities that have applied and been selected as, kind of community-based research sites or initiatives as part of phase 2 of the work. I think I would say that those applications or research proposals have been really grounded in connection and kind of reestablishing connection and in-person ways of being together. In terms of phase 1 conversations, though, I think a lot of community members, maybe not virtual counseling, but I know a lot of outreach. Like we had one team from the north who talked about how they were in constant communication via text as an outreach, way of maintaining relationship and checking in and things when they didn't always know where folks were going to be, and they may not always feel safe or have access to be able to get in to the center for programming and things. And so in that way, there was some kind of virtual elements, but I wouldn't say that we've had a lot of conversations about actual virtual counseling specifically. Aaliyah or Amity, do you have any thoughts on that?
Yeah, we didn't hear it in this, but I wonder if that's due to the timing of when we did our data collection, because I think that was probably happening a ton during COVID. But I'm not sure about now. It didn't come up. I think actually the opposite was true. We were hearing about a lot of folks who are like visiting people's homes to provide counseling. And like I saw a question in the chat or a comment about having low enrollment or like low people were not really participating actively in programs. And I know folks were doing a lot of outreach to people's homes who might have been concerned about stigma or identification in a small community about their substance use. So I think there was actually a lot of in-person activity happening, but not a lot. We didn't hear much about virtual, but I think that's an important part of the work as well, especially for folks living away from home.
Thank you. Well, that is our last question. Do you guys have any closing remarks before we end this webinar?
Thank you everyone for attending and joining. We really appreciate everyone taking time to be engaged in the work and to learn and listen and share back. And I also just realized I was responding in the chat to comments and it was only going to the staff and co-presenters and not to everyone else in the chat. But I wanted to say thank you for the engagement in the chat. It means a lot and we appreciate it.
Yeah, A huge thank you to everybody for your time and the expertise and the many gifts that you bring to this conversation. It's been a privilege to get to hear about the work that you're doing and what's resonating and important to you in this work. And please feel free to reach out to us. We would love to hear from you and collaborate and learn about the work that you're doing and see how yeah, our worlds and our work overlap in many different ways. So would love to connect in that way. So tapping the side.
Just echoing what Ashley and Aaliyah said, and thank you so much for your time. And we really look forward to any further collaborations with you all.
Thank you so much. So we are so excited that we got to connect with you. I know this is such a meaningful project and report, and I know the amount of people who were tuning in. The chat was very engaging questions, and everyone wanting to support this sort of work is just amazing because like we need this, and we want so many of our community members to have access to this care. And yes, thank you. And tuning into our next webinars, we have planning for healthy communities. That's on November 25th from 10 a.m. to 11:30 a.m. Pacific Standard Time. And then we have keeping in solidarity, self-care, community care, and ethical leadership in Indigenous health, featuring Len Pierre. That's on December 4th from 10 a.m. to 11:30 a.m. All of our webinars are free to sign up for on our website at www.learningsircle.ubc.ca. We look forward to seeing everyone at our next Learning Circle. Limit, thank you.